Again, thank you for having me. It's a real privilege to share with you a little time here. Of course, have written this textbook on bypass surgery, and everything that I'm going to share with you is in the book. But what I thought I would do is just kind of take you through what I consider to be the tenets or the real key learning points that hopefully you'll have a chance today to practice in the lab and go through. And these are them. These are basically the 10 different chapters that go in the tenets section. And let's see. So first one is dexterity. We don't really talk about dexterity all that much, but you should give some thought as to what each of your 5 fingers is doing. I like to think of the first 2 fingers as your actuators. They're what hold the instrument, your thumb and your index finger. And that's obvious to all of us. We all are used to that from even just eating with fork and spoon and so forth. But what really you need to think about is how you stabilize your hand. It's those your third and fourth digits, the middle and ring fingers that are so critical in stabilizing the instrument. They get underneath it and really brace the instrument and make it stable. The other part about support is underneath here. This is the 5th finger, and you really want to get as much of that part of your hand down on the surface that you can. So these are some illustrations that just show you the different ways to support the hand. Ideally, you want to be up here. Can you guys see my mouse?
Yes, we do.
Okay. Yeah, so you want to get the whole hypothenar eminence and your 5th finger down on the table. And if you were looking at this through a glass table, this is what it would look like. You see that maximum surface area underneath that's bracing your hand. That's what you want. When you fall short of that, you sometimes don't have the ability to get your whole hand down. You have to either do what I call a front brace, which means rolling your hand forward, and you're only touching that part of the distal part of your 5th finger, or a back brace where you're kind of rolled onto the hypothenar eminence. And that's less ideal. Sometimes if you're really in an awkward way, you have what I call a point brace, or just getting a finger down. And if there's no brace, if your hands are free floating, you'll find that your hands are much less steady, and it's really no way to be doing a bypass. You really want your hands to be rested and supported. Your instrument selection is really critical. The selection of your instrument is key. If it's too short, well, if it's the right length, your hand will be fully rested and your instruments will be right at the proper depth. If the instrument is too long, you'll see that it'll raise the hand up off of the table. It's here trying to get the tips at the right place raises your hand up, which is not what you want. The depth of your field will change. Sometimes you're working very superficially and a short instrument is the right one. Other times it's a long instrument for a deep hole, and that's the right instrument. So I have a variety of different lengths, and I will alternate back and forth. Now, I operate when I do bypass surgery seated. So you want to be sitting, you want your hands resting on an armrest, and you want good posture. So this is the kind of look that you want. You don't want to be like is shown in B, where you're hunched forward, have too much weight on your elbows, and you're just awkward. Your torso will tense up, and you just can't get that relaxation. Next is donors. There are multiple donors. You need to think about more than just the superficial temporal artery. You need to think about the frontal branch, the parietal branch, but also the occipital artery. Those are the big 3. So there's usually 3 arteries to choose from, not just one. And in many cases, you just need to be observant, seeing where you might be able to pull in an artery from. When it comes to harvesting these vessels, you want to lift up on the scalp flap. It helps to separate the vessel from the loose connective tissue. and you can follow that artery along its course. When you harvest, you're looking for these branches. They tend to lie at the outer curve of these serpentine curves of the artery, and that's where you'll want to cauterize and divide them. So usually you want to keep a little separation to protect the main trunk, and so that 2 millimeter distance is what you go for. I often will leave this connective tissue around the artery just as a way to protect it. This is another technique that some of the Japanese neurosurgeons will use, this bipolar cutting technique. It allows you to cauterize and kind of snap the artery free. It takes a little practice to get used to that, but it's another way to do that. The stripping of the connective tissue is a little secret that you can use to lengthen the artery. If you get rid of that, you can straighten the artery, take advantage of those curves that lengthen the vessel so that you gain this extra delta here that's extra length if you're finding that your vessel's too short. So this is to just show you the craniotomies I use. I typically will do just a small craniotomy under the superior temporal line, right underneath the artery. I can do that exposure through a linear incision. If I'm going for both branches for a double barrel, or if the frontal branch is the better of the two, then you want to make this arcing incision here and peel the flap forward. Those are the different exposures that you can use. This is really important. This is about creating the zone, what I call the zone, which is really setting up an environment where you can work, where things are clean and your visibility is good. You want a rubber dam underneath your working space. You need to place a little suction underneath to dry the field. You want a little Telfa strip here to protect the brain. A retractor is really nice for the deep bypasses, because not only does it hold your suction tubing in place, but it also opens the field and frees up your hands. You need a cottonoid sometimes to keep the holes of the suction device from clogging. And this is really what makes that working space. You don't have to worry about that so much in the lab, but you do have to worry about that in the patient. One of the key things is cross clamping. There are zones where you can cross clamp an artery and not have trouble, what I call the green zones. These are things that are beyond the circle of Willis and beyond the perforators. So you got to get past the lateral lenticular striates. You got to get past the thalamo perforators. You got to get past the medial lenticular striates on the A1. But once you're in those green zones, you can usually cross clamp and not worry about ischemic problems. If you're in the red zone, it's another story. There's very low tolerance for those kinds of cross clampings. Now this picture here is meant to say that there's steps you can do in advance that minimize the steps needed while the cross clamping clips are on. So load your needles onto the donor vessel, mark the artery. These are just little things that consume clock time that you can do in advance. What gets you through when you're cross clamping is the fact that there's collateral circulation. You've got these leptomeningeal connections that connect the MCA territory with the ACA territory with the PCA territory, and on down in the cerebellum, same story between ICA, PICA, and SCA. So it's these collateral connections that allow you to do your cross clamping with good physiologic tolerance. Now, arteriotomies, there's 7 different arteriotomies shown here. The linear arteriotomy is probably the best because you can make this 3 times the diameter of the artery. If you look at this perpendicular transection arteriotomy, you only get so much from that. You can get a little bit more by obliquing it, and you can get the maximum amount by fish mouthing. The fish mouthing is really critical. I'll show you in another slide the math behind that, but you expand your anastomotic area by a factor of about 4 compared to this. There are other ones. The excisional arteriotomy, just cutting out a little piece of tissue, is great, particularly for large arteries like the common carotid or the external carotid, where you can use an aortic punch. You can also use a bifurcotomy here, or using the bifurcation of 2 vessels to expand that tissue there. And you can also do an incisional bifurcotomy, which means cutting into that branch here, that Y, and that adds extra length to your to your arteriotomy. So here's the linear incision arteriotomy. I usually use a beveled needle, make a little puncture site. I've got these really nice angled micro scissors that extend that incision and allow you to get that opened up. This is that math slide I was telling you about. If you do the math, the area of this is 2 pi times the diameter. You look at the area here, it's pi times diameter squared. So it's a dramatic increase in the amount of area that you get by making the fish mouth. So whenever possible, I make a 60-degree cut. I make a linear arteriotomy here that's about the same length as the oblique transection. And then I fold out these and convert this into a quadrangle or quadrilateral. And that allows you to really open this up and maximize the opening. This is that excision arteriotomy done either at the micro level with an 11 blade, or here you can also do that with a aortic punch. These aortic punch, particularly this figure of 8 punch technique, makes a nice big hole, particularly for these high flow grafts. These are just examples of the bifurcotomy. Depending on how you slant that, you can lengthen the area. And these, again, are ways of increasing that anastomotic area. Needle anatomy is key. We don't talk about this much, but there are various needles out there. They're defined by their length, by the cord length, which is the distance as the crow flies from the point to the swage. And then there's this, this radius. So, you know, you have the circle that you typically use. We usually use a 3/8 circle when we do bypass. This is the ideal. We also use what's called a BV 75-4, which means that the 75 refers to the diameter here, the diameter of the needle, and you want that as small as possible, particularly for these moya cases. And then the 4 is the cord length. So this is a 4 millimeter cord length on this 3/8 circle. So the BB 75-4 is usually the needle that I go to. And you want to make sure that when you're doing your bypass, you select the right needle, because if it's too long or too thick or not the right cord length, it can be more difficult to do the maneuvering. So to break this down a little further, I usually take a single bite and break it up into 4 different parts. There's the bite, which is the passage of the needle through the tissue. You can see on these insets here at the bottom how you want to really get your instrument underneath the entry site here and use counter traction. But then it's a passage of the needle through the tissue. Once the needle's through, you've got to grab it and release your needle driver. That frees the driver hand to come off of the needle, but you never want to let go of the needle and let it be free floating in space, because it'll get away from you. So that's number 2, is the grab. Number 3 is the counter sweep. You want to push that tissue off of the back end of the needle, and you do that with your driver. So your forceps hand is stabilizing the needle. You push the tissue off the back, and then you've completed your bite. If you pull on the needle, sometimes you can tear through these thin MCA tissues, particularly in the small children, these 3-year-old, 5-year-old moya patients that have very fragile tissue. And then lastly is the reload. And you want to reload with your hand supinated. When your hand is supinated and you've got the needle in position, then you just flip your wrist and you're ready to keep sewing. If you reload in the pronated position, then you've got to awkwardly flip the instrument. And there's a lot of fumble factor in getting ready for that next bite. This slide shows you the various types of stitches. You know, I think the way I think about it, they're the heel and the toe stitches, and that applies to the fish mouth donor. When the fish mouth is in play, it has a heel and a toe. It's a definite orientation, but you want those first 2 stitches to be your anchoring stitches at the heel and the toe. I usually do the heel first because that's the hardest to place, and by doing that first, you can roll the donor vessel backwards and forwards and get a better view. The toe is easy. That's just through a little triangle of tissue, so you can see that without needing that roll of tissue. These next bites are the corner stitches. That's the one adjacent to the anchor. And once you've got that in place, then you can run the stitch from one end to the other. So this is a running continuous stitch. Here's your other corner stitch at the other end. It's right next to the anchor. And that's got to be well placed because this is often where you're really worrying about a through stitch, which grabs the other wall, or a leakage at that point. So those are the different components. And then you do the same thing running on the other side. When you're talking about an in situ bypass or a side to side, you have not only your anchoring stitches, 1 and 2, but then you've got what I call an entrance stitch up here. That's a bite that passes the needle from outside to inside before you can actually start running your suture. So you've got an entrance stitch before you begin. You've got an exit stitch here before you exit. And of course, you've got the corner stitches, the first and last bite before that. And in any event, you're sewing between layers, so this makes it a particularly challenging kind of a suture. Next is this interrupted suture. For those of you who do the interrupted, you can put your 2 anchors down, you can do a middle stitch, and then you can just split the difference, or some people will actually just intermittently space 3 bites between their anchors and their middle stitches. This is the heel and the toe stitch, and the point here is that I usually do a surgeon's throw for that first knot because it doesn't slip, and sometimes these vessels are wanting to pull apart, and you don't want that knot to come loose, so you need that surgeon's knot to really anchor things down. And the same is true on the toe stitch. You want to anchor that securely. These are some higher power views of that entrance and exit stitch for the side-to-side anastomosis. Again, just coming in right underneath the knot to bring your needle to the interior before you start the run. And on the other end, there's your exit stitch, just again coming out underneath the anchor, and then you can tie things down. The stitches, you want to look at the thickness of the wall down here. That's X. The bite should be about 2X distance from the edge, and the spacing here between bites is about 4X. So for any STA-MCA bypass, I usually put about a dozen bites from one side to the next. So in total, it's about 2 dozen bites, and that's what you want to look for. This is what you don't want. This is what's called a through stitch. If one of your bites here has grabbed the opposite suture or opposite tissue, and that's a through stitch. It will close off your anastomosis and has to be fixed. And if it's a simple edge here, you can trim that and free that little piece, and that's an easy fix. If it's a through stitch that goes through the vessel wall, then you've got to cut that stitch out, release the tissue, and then put a rescue or repair stitch in there to try and salvage it. So it's a little bit more work to do that, but you can't just pull this out and leave a hole in the wall there. Tissue handling. There are definitely good ways and bad ways to handle the tissue. This first picture here with the spread is generally how I like to do it. Putting the 2 tines of the forceps underneath your bite and then applying counter traction. What you don't want is what most beginners do. They just grab the tissue here and pass the needle underneath, but that's a traumatic hold of the tissue, and will get the platelets all fired up here and potentially close off your bypass. So you don't want that. The straddle is when you just use one of the 2 tines. You've got the 2 tines together here as a probe. You can do it that way. And this is another really nice way, what I call the tenting handle, which is where you use the forceps on the outside of the artery and just sort of lift up on the adventitia. And that allows you to place the tissue right above the needle and make your bite from there. For the deep ones, you've got to do a little everting, and that requires sometimes a special instrument and a different way to manipulate the tissues there. This emphasizes that counter pressure maneuver where you spread the tips and you get a tine on each side of the entry site and drive your needle in between it. It creates this rectangular area of counter pressure, which is the best way to pass the needle. When you only have 1 tine or a probe, you get some counter pressure. It's not as much, but it's better than nothing. And then lastly, for things like a tenting presentation, just a little point kind of pushing the tissue down on the needle is a way to apply some counter pressure. These are meant to just emphasize that when you're sewing, you've got what I call a stitching axis, where that's the axis that the needle is going into. And then the anastomotic axis, which is typically the line of the tissue. And they're usually at right angles. So you have to line things up so that your sewing hand, your dominant hand, is comfortable. You want that needle to be coming in where your hand comes in, if you're left-handed, along this yellow arrow here, and your needle is perpendicular to that. And that's really the ideal direction of sewing. If you're right-handed, it's a little different here. But this is the way that you want things to line up. And I like to think of it in this term. There's sort of a green zone that for me is between 1 and 3 o'clock, right in here, as a left-hander. For a right-hander, it's between 9 and 11 o'clock. But that's where you want your anastomotic axis to be. That's where you essentially want the line of the tissues to line up, so that when your needle comes in, it's coming in at a very favorable stitching axis. So you'll get a sense of those axes as you practice today in the lab. And what's nice about the OR setup is that if you're operating on a chair with wheels on it, you can slide around and you can move yourself into the right angle so that you're sewing in the right direction. With knotting, a couple points. You just want a very short tail so that you're not chasing a long tail. You want a loop length that's about 3 times the tail length. And you want this to be nice and tight so that you can do a quick wrap, here a surgeon's wrap, and then a pull. When you go to cut, you can, if you grab this little tail between the end of the suture like this, you're kind of lassoing in the strand. It allows you to grab both in one bite or one hold and then make a quick cut of the tails. You want to tighten these things properly. You don't want them too loose or too tight. If it's too tight, it will strangulate the tissue and narrow your anastomotic area. If it's too loose, you'll have some leakages. So you really have to get a feel for that tightness. And then lastly is, once you do the bypass, if you're doing it for an aneurysm, you may have more work to do. You may have to chase down the aneurysm either by trapping it, doing proximal occlusion, or what have you. So that's generally, those are the tenets. I'll just take you through this little sequence. This shows you a pica bypass, a ICA bypass. And here you can see the donor and recipients coming together. There's the marked line and the temporary clips for your cross clamping. Here's the beveled needle making your initial arteriotomy. Then your micro scissors come in and you extend that arteriotomy 3 times the diameter. Here's the anchor stitch being placed to bring one end together, and then the tie using the surgeon knot. Notice the double wrap there. On the other end, you place your other anchoring stitch, and you can see that going in. And then we do our running continuous here from one end to the other. Here now we tighten the loops. If you're just starting out, it's helpful to just keep the loops of suture loose and then go back and tighten them rather than tightening them on the fly. As you get better and you're more focused on your times, you can tighten on the fly. Then you tie things down. You flip the artery to the other direction. You can inspect the suture line, make sure all the stitches look good and there aren't any through stitches. And then you continue with your running suture on the opposite side. So here we've finished, we've tightened, we're tying it down. And then as the clips come out, you always want to see a little bit of bleeding there. That's a sign that there's good flow, and you just need to be patient for a minute or two, and the platelets will set up and get that bleeding under control, and then you're done. So with that, I'm going to stop. Let me exit my screen share here just a second. There we go. Yeah, so those were the points I wanted to make, and hopefully hopefully that was helpful.
Yes, thank you so much, Professor Lawton. Thank you very much for your book has been something that we are continuously going back to and mostly here in the course, like all your classification of the first generation all the way second generation. Today we are practicing a second generation, so it's been amazingly helpful and inspiring to see all your experience.
Thank you. I appreciate that. Well, it was a labor of love to write that book. It's my favorite of the 7, and glad you like it.
Thank you so much. I just want to ask if somebody has any questions. ¿Alguna pregunta? ¿Alguna duda? Somebody? No? Okay.
All right. Well, I've got a meeting to run off to. I appreciate being able to join you guys, and happy suturing.
Okay. Thanks a lot. Take care. Take care. Bye-bye.
Okay, bye-bye.